and I will be highlighting on the surgical management of controlling the postpartum hemorrhage. As we all know, this is the last 20 minutes we have in our hand where we can save our life. We have done already the medical management as well as the uterine balloon therapy, which is a sort of an intermediate so that we can buy some time and transfer the patient to an appropriate setup or an OT. So we already know that postpartum hemorrhage is severe if it is more than 1000 ml with hemodynamic instability. Timely escalation, timely intervention saves lives, which is very, very important that you need to hurry up and control bleeding as much as possible. So for surgical options, we have compression sutures, we have stepwise devascularization, and a hysterectomy. Integrated management bundle, which we have already learned, and I would just like to add that repair of genital trauma and an MRP is very, very important whenever we are conducting any delivery and we see that the bleeding is a little excessive, as well as the resuscitation with fluids as well as uterotonics go hand in hand, and a balloon tamponade and surgical options are always on the second line and third line options. So when to move to surgery? When there is persistent bleeding despite the initial measures. Hemodynamic instability is there, and a massive transfusion protocol has already been, there's need to activate it. So genital trauma repairs, I won't be going in dealing with this because we already know how to inspect and suture any torn cervix, vagina, perineum, and any uterine extensions. We have to repair it as fast as possible and explore and ligate for hematomas. Uterine atony is the most common cause of PPH. Almost more than 70% causes are because of uterine atony. And Bakri balloon is a very good intermediate treatment which buys us time, and it controls bleeding almost in 86 to 90%. By the time we shift the patient to the OT, patients usually will be well settled. But if it does not occur, or at the time of cesarean when we are dealing with a atonic uterus and the uterus is bleeding, we must know compression sutures. I think every one of us have already either used it and they have found it quite useful. But those who have never used it, they must learn and use it in their practice. This definitely saves life. So compression sutures, we have many types of compression sutures. You just have to get familiar with the most commonly understood and most commonly whatever is you can follow completely so that you can apply it very nicely and effectively. We have Beelen sutures, we have Heyman, we have Cho sutures. These are all should be done with absorbable sutures. So either chromic catgut, that is the preferable, number 1 chromic catgut, but sometimes the catgut gets breaks, so then we need to use Weichel suture, which is also absorbable suture. However, it is delayed absorbable. We must keep in mind whenever we are using Weichel, we have to take precautions. I will just tell you how. And we should avoid excessive tension so that it does not cut through the myometrium and causes more bleeding. And we should always document the technique what we have used in our practice. This is a Beelen suture. This is the first, I think, compression suture which had come in practice, where Beelen has demonstrated very effectively, and many people are using it day and night, And there we need to see how it is applied. So here we have an uterine incision, and 1 centimeter below the lower part of the incision is 1 point. 1 point is above the 1 centimeter from the uterine incision. These are A and B point. C and D are at the back, almost at the level of uterine incision. E and F are similar to A and B points on the other side. So what we do, we start from A, from the anterior part of the myometrium, we go in the cavity. Then we come out of the cavity through point B, from inside out. Then we loop over the uterus, and at the point C, which is almost similar to the back of B, from outside uterus, from the posterior surface of the uterus, we come in the cavity, and at the point D, we exit posteriorly out of the cavity, again come over the uterus fundus, make a loop, enter the uterine cavity from point E, exit it from point F, and then we tie it. So we tie it in two ways, First, we should pull this limb at the point C and D, this thread, and then we should pull out the other end, so that the uterus is well compressed. To some, it looks very confusing. कौन से point से अंदर जाना है, कौन से बाहर से आना है, and at the time when the patient is bleeding, there's not much time. Sometimes atonic occurs when we have already closed the uterus, and then the atonia occurs. Then the next modification is very, very important. This is Heyman suture. And this is my most favorite suture. I think I have taught all my senior residents who were there in Hedgewar. Everyone, each SR who had passed out during my time in Hedgewar had learned this suture from me personally, and subsequently also I keep on teaching whoever needs to. This is a simple suture. Just remember 2 points, A and B. Okay, this is at the level of below the incision line of the uterus, the lower segment. From this point anteriorly, we straighten out a needle. What I do, I straighten out a number 10 vicryl needle, because straight needle is not usually available. So with the end of the needle holder and an artery forceps, I just gently straighten out a needle, just leaving a slight, avoiding the tip, tip should not be damaged. And then from this point, from anterior to posterior, just come out through and through the uterus. Go posteriorly, and the best way is to hold the uterus, both anterior, posterior part of the uterus, in between thumb and 2 fingers at the back. And you should aim to go just straight perpendicularly to go back and try to exit in between your 2 fingers. By this, you're retracting the bowel away as well. You are entering in between your 2 fingers, you're not hurting yourself as well. And you know when the tip is about to come out. Ask the assistant to take an artery and then just gently pull it out. It's very simple, very easy. Not to go in and then find out where is it. Just mentally have a makeup that in between your thumb, just below the thumb you're entering, and you have to exit in between your 2 fingers, which is at the back of the uterus. You will not go anywhere else. And then once you are out, just pull over the loop and tie it. Similarly, repeat it on the other side. Just 2 sutures are usually sufficient, though Heyman has said that 2 or more suture can also be applied in a similar way. So like you can have 2 loops, you can have 3 and 4 loops as well. वो भी मैम बताएंगे, वो बीलिंच का है, वो उसमें आ जाएगा select devasculation में. This is another, Heyman says that in patients where the lower segment is bleeding, there horizontally Heyman suture can also be applied. Instead of applying vertically, we are just going from this point, going at the back and coming out from the back to outside, and then just tie it here. Similarly, a horizontal suture can also be tied, and if the bleeding from the corneal end, similar thing can be done. So it is through and through, anterior, posterior, entry from anterior, go out posterior, from posterior to anterior, come and suture it. This will control bleeding in almost 100% of the patients. You may not need to go further if you know this. So compression sutures, they are used ideally by chromic catgut, but vicryl can be done. And there was always a fear that vicryl is delayed absorbable, uterus will shrink in size, and the loops will be hanging over, and the rabbit ears and intestine can go in. Though cases have been reported, but in my clinical practice, what I have seen, I can tie the 2 loops also on the fundus. We join just the cut end of the tail end of the thread on both the loops at the top of the fundus, just tie it together. By tying it together, it just compresses the myometrium. And peritonealization occurs over it. And in 2 cases, I had to reopen a patient after 3 days in Hedgewar only. I think you were there, Kirti, I don't remember. Then I had seen that peritonealization has already occurred very well over it. So the chance of fear of a thread being loose and delayed absorbable, that intestine can get in, is literally you should not be that scared of. Just tie it completely so that it indents the myometrium. Once it indents it, it gets buried. However, post-op complications have been reported of like hematometra, especially with the transverse sutures. Pyometra, if you get infected. Asherman syndrome, we are going through and through the cavity. If you are using multiple sutures, then this can be a possibility. And the localized areas of necrosis and full thickness defects in lower uterine segment and fundus has also been reported. Just keep in mind, sutures are effective when PPH is caused by atony. Compression sutures have been reported to effectively manage hemorrhage in about 80 to 90% of the cases if the suture is placed in expedient manner. Whenever we are doing a cesarean, we finding a atony is there. By the time the medical management is being done, and we see that the medicines, injections which have been given, like they are not responding, then don't hesitate. Don't keep on doing a massage, hot pack, wait. No. Apply Heyman suture then and there. A stitching time saves 9. I think this is the one. It significantly reduced the number of hysterectomy done for postpartum hemorrhage. These are the basically the literature which I have taken out, and they have all said that it is very, very effective. Cho sutures are also very easy, and all of us should know it. These are box sutures. Point 1, 2, 3, and 4. We are entering from point 1, coming out from 2. Basically, we are going through the posterior myometrium as well. Through and through, anterior से निकलो, posterior से निकलो. फिर posterior से वापस आओ, anterior से बाहर निकलो, and then just tie it. So these are the box sutures. 2 can be applied over here, and even in the lower segment to control the lower segment bleeding whenever in cases of placenta previa. Prera sutures, personally I had tried in one patient, and not exactly Prera sutures. I had applied 2 Heymans, still the bleeding was not controlled, so I had applied the transverse sutures like this. 2, 3 rows I did, yeah. What you do, superficial bites, just take it in a running matter. In a running manner, you start from here, take a small bite, go in, don't go till the endometrium. On one side, see the avascular space of peritoneum in the broad ligament, enter posteriorly, posterior running suture towards the posterior at the same level, then again pierce the broad ligament at the avascular level and come here, and then tie it. So these 2 or 3 running sutures makes like a bursting sutures, and these constrict the vessels on the sides. Definitely this is going to control bleeding. Yes. नहीं होता. Use a round body needle, which we all use round body. Don't use a cutting needle. Round body needle does not bleed. And don't swagger the needle when you are inside. Just be clean in, just like a running, जैसे पोटली का मुंह बांधते हैं, just similarly. But वो broad ligament में side में देखना है, avascular plane से posterior जाना है, फिर posterior से आगे आना है. And बंद हो जाएगा, और कोई bleeding नहीं होती उस पे. I feel that this should be applied only when the bleeding is not getting controlled, because there's a higher chances of getting a necrosis later on in this type of sutures. This is another ball technique which is similar to bilge. Here 1 loop by 1 thread, another loop by 1 thread, rest all is similar. Instead of making 2 loops by a single thread, this has used only single thread. I think this is the Ashoka Anand stitch, which everyone should learn. I think it is clear. I will share the PPT and the images. What is being done is, you can see this needle coming out. These are 2 sutures on either side. From here, this is just 1 centimeter above the fornix, above the bladder reflection. Go through and through posteriorly, just like you go in Heymans. From anterior, uterus is like this. From just above the bladder, you just go straight and come out posteriorly at just 1 centimeter above the fornix. Then from posterior to anterior, you come out just below the level of uterine incision and tie it. Os यहाँ पर है. यहाँ से आप पीछे गए, पीछे से बाहर आए और आपने बांध दिया.
Uterus के margins पे. It's on the margins of it.
Needed. Ma'am, give me some time. Give me some time. सबको समझा के भेजूंगी मैं आज. Needle is inserted into the cervix from anterior to posterior, 1 centimeter above the level of lateral fornix and 0.5 centimeter medial from lateral cervical musculature. जो यहाँ पे lateral cervical musculature है, उससे 0.5 centimeter अंदर रहना है. So there is no chance of injuring the ureter. The same needle and suture is reinserted from posterior to anterior, 0.5 centimeters below the lower edge of the uterine incision on the same side. This is how it looks on the posteriorly. This thread you can see posteriorly, just inside, 0.5 centimeter inside the margin of the uterus. So ureter obviously is going to be far, far away. Posterior view, the needle exits posteriorly, 1 centimeter above the level of lateral fornix on the same side, re-enters the uterus from posterior to anterior at the level of edge of uterine incision. This stitch is based on the reasoning that taking the stitch bilaterally occludes the collateral supplying the lower segment, as these are end arteries and their occlusion causes hemostasis in the lower segment. How the uterus gets its supply? From the vessels which runs parallel. So this lower segment is supplied by the vessels which are running parallel. There are sinuses which are running parallel. So if you occlude by this suture, the bleeding is definitely going to get controlled in lower segment. So it does devascularization lower segment, especially useful in cases of placenta previa. It is very, very safe because we have seen that by no means we can injure the ureter and bladder in this. It's easy, anyone can learn it. It's very, very effective. Next is stepwise devascularization. In fact, stepwise devascularization, there are 2 steps. One is at the uterus level, one is at the iliac level. So I have just divided into stepwise devascularization 1 and 2. So stepwise devascularization, we have uterine artery, we add utero-ovarian if needed, and it is fertility preserving, we save the uterus, most important in cases of primipara. So this was a novel method which was published in 1994. 103 women with uncontrollable PPH were subjected to 5 steps devascularization process where PPH was controlled in 100% of the cases and hysterectomy could be prevented in all. So what is stepwise devascularization? There are 5 steps. 5 successive steps. You don't have to do 5 in all, but you have to do it 1, bleeding controlled, okay, don't go further. Bleeding not controlled, go to step 2. Step 3, step 4, step 5, till the bleeding is controlled, right? So first step is unilateral uterine vessel ligation. You ligate the uterine arteries of that side. If it is not controlled, ligate the other side. So you have bilateral uterine artery ligation. So almost 50 to 60% of the bleeding will be controlled by this. Still, if the bleeding is not controlled or if there is a placenta previa, you need to do a low uterine vessel ligation. This unilateral bilateral uterine artery ligation is done at the level of the cervical incision which we give for caesareans. Low uterine is given at a lower level, at 1 centimeter lower than the uterine incision, and it controls the descending branch of the uterine arteries. If it is not controlled by all this third step, 4th step is unilateral ovarian vessel ligation. Need to ligate ovarian vessel of one side and ligate the bilateral ovarian vessel ligation can also be done if it is required. But usually, very rarely we need to go to here. If you are combining compression sutures with stepwise, I don't think we should go for step 4 and step 5 because then there will be necrosis. Complete devascularization will cause lot of chances of post-op. Utero-ovarian, that's what I said, bilateral utero-ovarian. It's not infundibulopelvic. यहाँ पे जो है यूट्राइन हमारी जा रही है साइड में यूट्रस के, we take a bite from the 0.5 centimeter or just less than that from the medial to the uterine vessels in the myometrium. We go out posteriorly and re-enter anteriorly through the avascular space of broad ligament, and then we tie it. We don't dissect the uterine artery and find it, you know. We just go above and below. Like this, in the one time we go from anteriorly medial to the uterine vasculature in the musculature of the uterus. We go posteriorly. Then from the broad ligament, we feel and see avascular plane. We re-enter anteriorly and then tie it. One side, other side, bilateral. Ligation of ovarian artery is done over here. Vasculature of ovary and tube is preserved. We are just blocking the anastomotic ovarian vessel which enters the uterus at the level of cornu. Here also we are going to go from the myometrium, go posteriorly, re-enter through the avascular space of broad ligament and tie it. This is very, very simple. If we cannot tie it here, we can enter from here, go posteriorly and come out just below the tube. We can tie it at this level also, along with the ovarian ligament, I mean. ये समझ आ गया सबको? This is stepwise devasculation too. This is important. This is technically challenging. Not everyone is daring enough to do it, but we must all learn it. At least in emergency, we should know what needs to be done and how you can do it. You'll find ways. You can call a person who can do it, you know. बहुत आसान है. Internal iliac artery ligation or hypogastric ligation, it reduces the pelvic pulse pressure to 85%. So the blood vessels, the pulse pressure is reduced, so the whole pelvic circulation becomes a venous circulation. So it becomes easier to control bleeding. However, it is technically demanding and we must be learning it. So this is the uterus and these are the internal iliac, external iliac vessels. We are going to ligate the internal iliac artery. And I think we should remember that we should be identifying the IP ligament and the round ligament. Lift up the peritoneum in between the two arteries, dissect it bluntly by your fingers. Your fingers will not injure anything. Just dissect, 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 and you will find the ureter just reflected medially. Identify the common iliac. It's very easy. If you're not able to see it, you can feel it, and then with the blunt dissection by fingers or an artery, we can reach the common iliac, trace the internal iliac down. And what happens? Here is the external iliac, here is the internal iliac. If you're just here, you're very close to the external iliac vein. You go 2 centimeters from the common iliac origin. Here it moves away from the vein and it's easier to suture it. So you can see this is the iliac vein, interiliac vein, which is going down, external iliac going down, and as you go above, from 2 centimeters down from the common iliac, this moves away from the external iliac artery and vein. And here it is easier. Posterior branch has also been given up by that time. This is the area, 2 centimeters from the common iliac. Just iski picture दिमाग में बना लो. From medial, from lateral to medial, you just enter it and take it. Lateral to medial, medial to lateral भूल जाओगे, लेकिन ये याद रखना है कि as close to the vessel as possible and try to be away from the external iliac vein so that you don't injure it. And you just tie it with any thread like vicryl or a silk. This is very, very important. Interventional radiology, now we have facilities available with us. All the leading hospitals in East Delhi, we have facilities where we can do the uterine artery embolization. But that can be done only if the patient is stable, facilities available, or you have a high-risk case where you are planning pre-operatively, where you will be needing in uterine artery embolization. And those cases are placenta, accreta, TAS spectrum. Here you should be doing in this where you have interventional radiology setup and where we can put the balloons before taking the patient for cesarean and then embolize the vessels so that the bleeding is controlled. If it is not there, then we have the option of internalic ligation only, which should be done as far as possible. The facilities are not there. So indications are uncontrolled bleeding, placenta accreta syndrome, uterine rupture. Hysterectomy should be done only in these cases as a last resort. But don't think last resort है, पहले सब कर लेते हैं. अगर पेशेंट लो हो रही है, ब्लीड हो रही है, इंटरनालिक नहीं आता है, फटाफट हिस्टेक्टमी करके पेशेंट बचाना is all the more important. Doing a hysterectomy late will not serve any purpose. It can be done subtotal as well as total, depending on the case, depending on the expertise available. All gynecologists should know cesarean hysterectomy. It's very simple, much easier than the gynae hysterectomies. It is life-saving and should be done as a last resort. Placenta accreta syndrome, we have to have a multidisciplinary approach. Caesarean hysterectomy with placenta in situ should be done. Placenta should not be forcefully removed. You know, it will cause torrential bleeding. Dictum is just remove the baby and do the hysterectomy without removing the placenta. Uterine artery balloon, if the facilities are available, there are people who have done even in cath lab, they have put the balloon in, did the cesarean, as soon as the baby is out, they inflated the balloon and caused the uterine artery embolization. An internalic ligation obviously may be required if uterine artery embolization is not done or not available. What happens if we cannot do anything? Damage control, do a pelvic packing. People have done hysterectomy, internalic ligation, despite that bleeding not controlled, pack the uterus, pack the pelvis, suture it, temporary closure, put the patient in ICU, build the patient up by giving her blood products, massive transfusion protocol, and once the patient is a little settled, is out of that coagulation profile is normal, then go in again and remove the packs. That also has been done. It has also been life-saving, but obviously, if you do all the steps within 60 minutes, you will not need this. ICU monitoring is important and post-operatively. Thromboprophylaxis is also important, especially by giving a deep DVT pumps to the patients. And fertility counseling is also very, very important, and then documentation and audit. Key take-home message is early escalation, stepwise approach. Don't go to step 5, start from step 1. Choose the least morbid and effective option. I think out of all those which I have described, hem and suture is the least morbid, very useful, very safe, very effective. Document and debrief both yourself, your team, as well as the relatives. Quality improvement, save future lives. Whatever you don't know, learn. Any age, we can learn new things. So this is the managing PPH following vaginal deliveries and cesarean delivery. I think we know both the things. Ensure no RPOCs, thoroughly inspect pelvis for injuries or trauma, ligate, lacerations, uterine compression sutures, B-linch or others, uterine balloon placements, devascularize the uterus by uterine artery ligation, utero-ovarian artery ligation, uterine tourniquet, hysterectomy, pelvic packing. We should know all this step in the systematic order. Thank you.